We will discuss the evaluation and testing process for jaundice, a condition where the skin and eye turn yellow due to elevated bilirubin levels in the blood.
Initial steps involve a thorough physical exam and a set of lab tests measuring bilirubin, alkaline phosphatase, liver enzymes, AST and ALT, clotting factors, and albumin. These initial findings guide further testing by revealing patterns that point towards specific causes of jaundice. For example, a cholestatic pattern characterized by a high alkaline phosphatase relative to AST and ALT suggests possible bile duct obstruction or impaired bile flow. In these cases, imaging is often the first step, typically an ultrasound to examine the liver and bile ducts. If the ultrasound shows dilated bile ducts without an obvious cause, further imaging like MRCP, MRI-based cholangiopancreatography, or endoscopic ultrasound, EUS, may confirm the blockage and help identify its source.
When there's no evidence of bile duct dilation, the focus shifts toward intrahepatic cholestasis, where the issue originates within the liver.
Here we explore possible causes based on the patient's history and risk factors. Certain medications and supplements may cause cholestasis, so discontinuing these is often a first step. Blood tests may then be ordered for conditions like primary biliary cholangitis, primary sclerosing cholangitis, viral hepatitis, pregnancy-related cholestasis, and other immune or infiltrative liver diseases. Each condition has specific tests, such as anti-mitochondrial antibody testing for primary biliary cholangitis or bile acid testing in pregnancy-related cholestasis. If lab tests and imaging don't provide clear answers, a referral to a liver specialist may be necessary, sometimes leading to a liver biopsy to rule out infiltrative disease. Isolated hyperbilirubinemia, where bilirubin is elevated but other liver enzymes and alkaline phosphatase remain normal, often points to issues unrelated to liver or bile duct disease. If the elevated bilirubin is unconjugated, the next steps include evaluating for hemolytic anemia, excessive breakdown of red blood cells, and stopping medications like rifampin that may interfere with bilirubin processing. Gilbert syndrome, a mild condition where bilirubin rises slightly under stress, is often suspected if unconjugated bilirubin is under 4 mg per deciliter, with no additional testing needed unless levels exceed 4 mg per deciliter or other abnormalities are present.
If isolated conjugated hyperbilirubinemia is found without other lab abnormalities, rare inherited conditions like Dubin-Johnson or Rotor syndrome may be considered.
These are typically benign and don't require treatment. When lab results show a hepatocellular injury pattern with high aminotransferases, AST and ALT, relative to alkaline phosphatase, this suggests liver cell damage. Further testing then focuses on determining the underlying cause, such as viral hepatitis, autoimmune liver diseases, or metabolic disorders affecting the liver.
Each of these patterns, cholestatic, isolated hyperbilirubinemia, and hepatocellular injury, provides crucial clues that help narrow down the cause of jaundice, guiding targeted testing, treatment, and if needed, referral to specialists for comprehensive evaluation and care.